Good morning. Happy Friday, everyone. Welcome to another edition of PT on Ice. My name is Jason London. I am lead faculty with the Institute for Clinical Excellence with teaching both the rehabilitation of the injured runner as well as rehabilitation of the injured cyclist. And today I want to revisit a topic that I spoke with about a year ago, and looking kind of at the myth of running and the development of osteoarthritis. And, do runners really have an increased risk of developing OA? But I want to reframe it a little bit more of a clinical picture and frame it in the patient with an ACL reconstruction. And the reason I want to do this is I think most of us are familiar that those patients who have gone to get an ACL reconstruction or even just a ACL tear have a higher incidence of early onset osteoarthritis than their normal cohort. And in a most recent issue of the American Journal of Sports Medicine, there's several studies looking at this. One study looking at the development of severe or patellofemoral OA, looking at graft types, found that there's no difference in terms of graft type, but after 12 years following the surgery, there is a rate of 20% of patellofemoral OA, which is pretty high. And another study was a MRI descriptional study looking at degenerative changes within the first 5 years after ACL reconstruction, also finding degenerative changes within those first 5 years occurring at a higher rate. And there's been other studies showing just an increased rate of either tibiofemoral or patellofemoral OA in those patients that have had an ACL, or ACL reconstruction. So we know that graft type probably isn't mattering, but what is their activity level? And certainly, have they regained full range of motion, particularly that knee extension seems to be a very important one. So really, should we be having our ACL reconstruction patients or patients with an ACL reconstruction getting back into running, and when should that occur, and how should that occur is the question. Well, the meta-analysis that I presented about a year ago was from the June 2017 issue of JOSPT, and that is looking at the rate of hip and knee osteoarthritis in recreational runners versus sedentary controls versus competitive runners. And what they found is really dispelling the myth that running leads to the development of arthritis. So what they found is after going through 17 studies and then having an N of over 100,000 people or subjects, is that the rate of hip and knee OA in those runners that would be classified as recreational runners, so runners running at a little bit of a lower volume, and interestingly, the way that the data worked out is those runners who have been running for 15 years or less had a much lower incidence of development of hip and knee OA than sedentary controls. So the incidence in recreational runners was around 3%, whereas the incidence in sedentary adults was 10% for hip and knee OA. And then interestingly, professional runners, so those runners who are competing internationally, were found to have a rate of development of OA around 13%. So quite a bit higher than the recreational runners and maybe just a little bit higher than the sedentary adults. So I think we can see from this study that running does not necessarily lead to the development of OA, and it may have a protective effect. There have been laboratory-based studies showing there is a chondroprotective effect in rats that run at lower volumes. Once they are running at higher volumes and higher intensities, that's when the degenerative effect comes in. So it really comes down to load in the body's ability to adapt to that load. So if we have people who are running at a lower volume, their body has more time to adapt to the load, and it actually could be a beneficial effect to the joint in terms of protecting it from OA. So coming back to our ACL reconstruction patients, we know that this group has a higher incidence of development of earlier onset OA for both tibiofemoral and patellofemoral joint. So we want to be careful here with them and get it really right when we're getting them back to running, which typically is going to be around the 3-month mark. And so what we want to do is, one, make sure that their knee is a nice, quiet, healthy knee, meaning that there's no swelling, they have return of full range of motion, and they have adequate strength and control to be able to run and absorb that impact. So a test that I use as a functional test is just, are they able to do 20 single leg squats to 60 degrees with perfect form, without pain, and then definitely that they have not been getting any post-activity swelling, and then getting them going on the treadmill and reintroducing running with doing a little bit of a run-walk program and making sure that they have some rest days in between. And then as far as how they're running, I think is important too, and that'll be really interesting to see as time goes on. And there's been more research looking at gait retraining, and really more recently some research showing using gait retraining for injury prevention in running related injuries, and how, if we're changing running form, particularly with patients with these non-related running injuries, how does that change the progression of OA? So going back now to looking at some other studies, there's been some great studies out of Brian Heiderscheid's lab as well as Blaise Williams' lab, looking at kinematic variables, so variables that we can see while someone's on the treadmill, and their correlation with kinetic variables, so those variables leading with the vertical ground reaction force, the braking impulse that's going on when someone's initially contacting, and the rate of load that's going through the leg. And so these are variables that these kinetic variables are ones that we really can't measure in the typical PT clinic unless you have an instrumented treadmill. So it's nice to have some kinematic variables, or variables that we can track and measure in our setting, that gives us some insight into how are those legs being loaded. And so what they found is, to just simplify it, is the foot inclination angle at initial contact, so the angle of just the sole of the foot to the treadmill. So if that is greater than 10 degrees, that indicates higher impacts and higher braking force. The stride length, so the distance from at initial contact, the heel to the center of mass, as well as the amount of vertical displacement. So how bouncy basically is the runner? Are they running from a higher, or are they landing from a higher height than they need to be? So basically all of those things giving us an idea of what are the amount of impact going on with that runner. And we want to minimize those impacts. One, as we want to have a little bit more protective effect at that knee, not especially if it's someone who's just coming off of a surgery and getting back into some loading. We want to mitigate the amount of load going through the knee and really being able to control that as best we can. So based on those studies, getting those patients with the ACL reconstruction back to running is probably the best time to be introducing some gait retraining skills to decrease impact. So decrease the amount of vertical displacement, decrease the foot inclination angle at initial contact, and decrease the stride length. And two methods that we can use to do this quite successfully are cadence retraining. So by changing their step length through that. So if we have them run at 10% over their self-selected cadence, so if they're running and you're calculating their cadence as they're getting back into running at 160 steps per minute, and then we have them run at the same speed at 176 steps per minute. That's going to decrease their stride length, and then also it's been shown to decrease the amount of vertical displacement with the center of mass. And that vertical displacement of the center of mass we want to keep under 12 centimeters. So that'd be one route to go. Another route to go would just to be giving them feedback on the impacts, especially if you can hear that they're landing more heavily. There's been some studies showing just telling the runner to run more quietly is a good way to do that. Or you can get out, there's other studies looking at use of decibel apps and having the runners just trying to minimize the decibels when they're contacting during running, and showing success there as well. So those would be two ways to get someone back into running after ACL reconstruction, with looking at some gait retraining. So cadence manipulation and basically getting them to run more quietly. And again, I think it's really important that we're just gradually getting them back into running, so increasing their volume slowly and making sure that they have rest days in there. So I think we can and should be having our patients following ACL reconstruction returning to running, again, usually around the 12-week mark, but doing it smartly to try to minimize any damage from overload of volume and impact as a result of running. So that meta-analysis that we talked about, or I talked about just a little bit earlier, from June 2017 is a great thing to go through, and there's a great patient handout or just education handout that you can also give to other healthcare professionals to show that, hey, running really does not necessarily lead to the development of hip and knee OA. Runners can run at lower volumes, lower than 60 miles per week, which for some people is a lot, and probably be getting a chondroprotective effect and getting, of course, much better health benefit from doing that as well. Everyone have a great weekend, and we'll see you later.